Welcome, everyone. My name is Heather McKnight, and we're glad to have you here for our PACES or Pediatric Acute Care Education sessions. Today, we're going to be talking about pediatric asthma management. My name is Heather McKnight, and I'm the Division Chief for Pediatric Hospital Medicine at UC Davis.
And I'm Leah Tzimenatos. I'm Chief of Pediatric Emergency Medicine here at UC Davis, and just want to also share my welcome. Thanks for joining us today. We don't have any financial disclosures to tell you about, but as you heard when you logged in, the session is being recorded for use as enduring CME materials. So by continuing on in our session, you're providing your consent for our recording.
I wanted to go over our objectives for today. So today we're going to be talking about how we can increase evidence-based care of pediatric patients, and more specifically with asthma, we're going to review the asthma treatment guidelines for emergency department and inpatient care. We'll talk about how we can utilize the pediatric asthma scores to guide our treatment based on severity. And then finally, we'll apply preventative measures upon discharge for our asthmatic patients. We wanted to give a little bit of background. Asthma has a really big impact in terms of our pediatric population that we see in the emergency rooms and in inpatient settings. 1 in 11 children in the US have asthma, and 1 in 5 children with asthma visit the ER each year. It's one of the leading causes of hospitalization for children in the United States. Next, we wanted to talk about kind of one of our major core pieces of our framework and how we approach these patients. And so the way that we kind of assess these patients and figure out the severity of their illness is to use our pediatric asthma score. You can see over on the right-hand side that our score has multiple components. And so there's 5 major different things that we look at. And then across the top, you can see we have 1, 2, and 3. And so depending on which category they fall into, we add a 1, a 2, or a 3 to their score. 3 being the most severe and 1 being the most mild. And so starting at the top, you can see respiratory rate. Our respiratory rates are stratified by age, so you can see anywhere from 2 to 3 years of age to greater than 12 years of age. For our 2 to 3-year-olds, they get a 1 if they're less than or equal to 34. They get a 2 if they're 35 to 39, and greater than or equal to 40 is a score of a 3. Our next major component is oxygen requirement. So they would get a 1 if they are greater than 95% on room air. They get a 2 if they're 90 to 95% on room air. And if they're less than 90% on room air or while also getting oxygen, then they would get a score of 3. Our next component that we look at is auscultation, or when we listen on our exam. So they would get a 1 if they have either normal breath sounds to potentially having end expiratory wheezing. They get a 2 if they have clear expiratory wheezing, and I think about that as the kid who has pretty diffuse wheezing that's obvious on your exam. And then finally, they get a 3 if they have inspiratory and expiratory wheezing and also may have diminished breath sounds. I think that is one of the trickiest parts of assessing some of these patients is sometimes these patients are so tight that you hear less wheezing because they're moving less air. And so some of those kids may fall into a 3. The next component is looking at their work of breathing, and so do they have retractions. They get a 1 if they have none or just have intercostal retractions, so looking kind of between the ribs and seeing it pull in. If they have intercostal and substernal retractions, then they would get a 2, and so both looking between the ribs as well as kind of at the base of the sternum, do they have that pulling in? And then finally a 3 if they have intercostal, substernal, and supraclavicular. So looking above the clavicle and seeing if you're seeing it pull in with every respiration. And then our final category is dyspnea. I think this can be a little bit more tricky in our younger population, but it gives us a framework to think about these kids. So are they able to speak in sentences, coo, or babble for our younger patients? They would get a 2 if they can only speak in partial sentences, if they have a short cry. Some of those kids I think of, especially our younger kids, where they're kind of more breathy and they're not able to get out that full cry. It stops short because they're trying to regulate their respirations. And then finally, in the third category, are they able to only speak in single words, short phrase, and especially for our younger patients, are they grunting?
I found that one, even in our patients who are older, can be a little bit tricky to assess because sometimes, at least, initially in the ED, they're pretty anxious and they're not talking much. One of the tricks that I've added into my practice recently, if I do have a kid who's being real quiet and I feel like I don't have a sense of sort of how much they're able to talk, is I'll ask them to count for me. and I'll have them count to 10. And if they're able to, get all the way to 10, I'll count that as a full sentence. If they get just one or two numbers out and then have to take a deep breath versus just one number out at a time between breaths. It doesn't work well, obviously, in our littlest kids, but I feel like at least in the sort of preschool to school age kids, it's helped me some.
And then once we have scored our patient, we then classify them as mild, moderate, or severe. So mild is a score of 5 to 7. The minimum score you can get for any patient is a 5. Moderate is 8 to 11, and then severe is 12 to 15, with the maximum score possible being a 15.
I was also going to just chime in here that this pediatric asthma score we chose here at UC Davis because there's some evidence that it's associated, higher scores are associated with increased resource utilization. But I think it's tricky because there are multiple scores out there, including several that are called pediatric asthma score. So it's just helpful to know kind of ahead of time what score you're using either at your institution or institutions that you're referring to, because the range is different for all of them.
And then I think for any of these scores, we had a lot of discussion around this, as well as like it can get confusing because we also use scores to evaluate patients with bronchiolitis, and they're two separate things in our institution. But there's different components. I think the other thing that struck me looking at this is that if you're working at altitude, which we're not in Sacramento, it also kind of shifts what some of your values may be. So I think is valuable as an institution to look at this and then kind of reflect in a multidisciplinary group about what works best in your institution and how to apply these things. So next, I wanted to use a real patient to go ahead and walk through our pediatric asthma score. So this patient that came in was a 5-year-old female with cold symptoms for 5 days. Who had presented with shortness of breath. Her vital signs, her temp was 37.7, her heart rate was 102, respiratory rate was 37, her blood pressure was 108/76, and she had an O2 sat of 92%. On her physical exam, she was alert, talking in short sentences. Her cardiovascular exam was unremarkable, and her lungs exam, she had diffuse expiratory wheezing and both intercostal and substernal retractions. And so we pull up our pediatric asthma score, and if we look through her exam and her vitals, we'll start off with her respiratory rate. So her respiratory rate was 37, and since she's 4 to 5 years of age, that gives her a score of 3 for that, with greater than or equal to 36. Her O2 sat was 92%, so that falls into the second category with a sat of 90 to 95% on room air. She was only able to talk in short sentences, and so that also puts her in the second category with a score of 2. She was noted to have diffuse expiratory wheezing, and so again, another score of 2. And then the final component of her exam, her retractions, she had both intercostal and substernal retractions, so she got a score of 2. So if we add up all those components, we have a 1, 3, and 4 2s, and so her total score is an 11. And then if we look at our different classifications in terms of severity of disease, with a score of 11, she falls into our moderate category.
So the use of a pediatric asthma score is actually a quality metric that's used as a benchmark in pediatric emergency departments across the country. It's also really helpful for us because we have used it very practically to put patients into a pediatric asthma pathway. We're actually in the very final stages of finalizing this pathway that we're showing you here, and which is sort of a combination of pathways at our institution, and we've basically tried to streamline them. So now we're getting one continuous pathway from the emergency department through inpatient care, either the ICU or pediatric wards, and through discharge. And so when we use the pediatric asthma score sort of in broad strokes in the emergency department, what we do is we assess the patient on arrival, and then we'll also assess them every hour for the first 3 hours of their care to sort of determine what interventions they need and then what period of observation we want to use if we're pausing their interventions as well. The two mainstays of treatment in our pediatric asthma pathway are albuterol and systemic corticosteroids. So I wanted to spend a couple of minutes talking about those before we move on to the specifics of the pathway. So albuterol, or short-acting beta agonist, is used. And when you look up dosing of albuterol, the dosing sounds straightforward. They say that we should dose it at 0.15 milligrams per kilogram for patients, which sounds great until you try to do that and you're looking at nebulized treatments, or even worse, if you're looking at inhaler and how to give that medication. It gets really complicated very quickly. And so what we've done is we've sort of moved it into unit doses based on the overall size of the patient. So for our patients who are less than 20 kilograms milligrams, we're calling a dose of albuterol either 2.5 milligrams via nebulizer or 6 puffs via inhaler and spacer. And then for our patients who are 20 kilograms or bigger, we're using 5 milligrams via nebulizer or 12 puffs via inhaler and spacer. For some of our mild patients, they'll get just one treatment, but frequently for our moderate or severe patients, we're giving multiple albuterol treatments. And so we'll sometimes administer 3 of those treatments back to back, so every 15 minutes over the first hour that they arrive. We've gone back and forth, and it's easiest in our emergency department to give those back-to-back intermittent treatments rather than giving it continuously. But certainly at some institutions, it's easier for physicians, nurses, and respiratory therapists to administer it continuously. And if that's the case, it's usually at 10 to 20 milligrams per hour. And there are some good studies showing that administration of albuterol via inhaler with a spacer device is equally effective to administration via a nebulizer. And so because of that, we can use other considerations when we're deciding which modality we're going to use for administration in our ED. So family preference plays into it some, but we also think about things like home use and education for patients who have not used an albuterol inhaler before or who we suspect are having some challenges with using it at home. If we know that we want to do education, sometimes we'll double up and we'll administer the albuterol at the same time we're giving education about how to use the albuterol inhaler with the spacer. We also all know well during COVID about aerosol generating procedures. So with nebulization being an AGP, if you're in a shared patient area, using an inhaler and spacer can be more advantageous than using a nebulized treatment as well. And then we're learning more and more that the propellants that they use in the albuterol or in inhalers in general are particularly bad for the environment. So if you're not in an environment where you're able to reuse your albuterol inhaler and it's just going to be a one-time use, then potentially using a nebulizer can be a better choice in those cases. And then again, sort of the other arm of our initial therapy is systemic corticosteroids. We can usually administer steroids orally in the emergency department. And again, there's some good studies that show that there is equivalent efficacy of either PO dexamethasone or PO prednisolone or prednisone in children. There's been some minor differences between the two. There's a little bit of increased vomiting if you use prednisolone compared to dexamethasone, and then a small difference in return visits for dexamethasone versus prednisolone. But the general thinking is that those sort of average each other out, and so both of them are equivalent. For our patients who are more severe, if we think they're not going to be able to tolerate PO medications because of, particularly because of respiratory distress, then we'll place an IV and give IV methylprednisolone for those patients. If you have patients in respiratory distress or who are vomiting and don't have an IV, intramuscular dexamethasone is another choice as well. But typically for our mild to moderate patients, we are giving dexamethasone at a dose of 0.6 milligrams per kilogram. There's a range of maximum doses out there. We use a maximum dose of 16 milligrams per dose in our ED. And then if patients are going home, we're prescribing one additional dose to be given in the next 24 to 48 hours. Data showing that a 2-day course of dexamethasone is about equivalent to a 5-day burst of prednisolone or prednisone. And then for our patients who are getting methylpred, we give that one at a dose of 1 milligram per kilogram intravenously, and we max that out at 60 milligrams. There's some studies that show that earlier administration of systemic corticosteroids can decrease hospital admission. And so we try really hard, particularly in our moderate to severe patients, to get these steroids in quickly. And so the hope being that we're going to give them a lot of albuterol, we're going to get their steroids in quickly and hopefully shorten the rest of the course.
I was just curious for the dexamethasone, in terms of the formulation. Are you guys using the IV formulation PO, or are you guys using like an oral disintegrating tablet, or what do you guys?
Yeah, that's a great question. We have gone back and forth between the two. What we're doing right now is we're using the IV solution PO for our patients who are too young or can't swallow pills. It's a smaller volume than the dexamethasone PO solution, which is relatively dilute and also tastes quite bad. So because of that palatability, it's really hard to get the dexamethasone solution in patients. For patients who are going home, even if they're too young to swallow pills, I still usually prescribe the tablets. And then I just have the family crush them and dissolve them in just a few, like I usually tell them like a half a teaspoon or a teaspoon of a liquid, so something like water or juice. And then I also tell them they can mix in like syrup or chocolate syrup or something that the patient likes to get them to take it, because it is such a smaller volume compared to giving them the oral solution. Some hospitals I know, and we did initially, had issues giving the IV solution PO because of safety concerns with crossing the to a different method of administration for the medication, and so that can be a barrier as well. And in those cases, dissolving the tablets tends to work very well also. Okay, so this is sort of a close-up look at the first hour of our pathway on the pediatric asthma score for the emergency department. And we're including patients in this pathway if they're at least 2 years old and have either a known diagnosis of asthma or have had at least 2 wheezing episodes in the past. The idea that we're trying to kind of select for patients who we think are albuterol responsive, so we're not doing all these interventions in a patient who just has viral-associated wheezing and might not respond as well. And then those patients present with either wheezing or with acute shortness of breath. And so after that initial assessment, they are categorized as either mild, moderate, or severe. And that's sort of when our break determines what treatments they're going to get. For our patients who are most mild, we will often just give them a single albuterol treatment and see how they respond. If they haven't needed albuterol in the 4 hours leading up to this and their symptoms completely resolve, then we can be done with that first treatment. We basically sort of observe them, make sure they're not having recurrent wheezing, and then we can discharge them home with education. Sometimes parents have run out of albuterol at home or are giving subtherapeutic doses, and so just getting them adequate education and adequate dosing is enough. But certainly some of these patients have been giving albuterol at home and are coming in with wheezing despite that. And so even if they're mild, if they get that initial treatment and they've either had recent albuterol or are still wheezing, then we will give them a dose of dexamethasone PO as we discussed. For our patients who are moderate or severe, then we're treating them with more albuterol. So we're using albuterol plus ipratropium, and we're giving those 3 back-to-back treatments. So it says every 15 minutes. Really, we're just sort of putting them in one right after the other, assessing them between treatments to make sure that they haven't sort of completely resolved. But often they're staying in sort of their moderate to severe category during those treatments. And then at the end, we're going to assess them again. All of our moderate to severe patients get steroids, and then as we talked about, it can be the PO steroids if they're safe to tolerate that, or methylprednisolone if necessary. I wanted to just touch for one more minute on our albuterol dosing because it is often significantly more than what families are giving at home. And sometimes it's more than what we see given at referring hospitals before patients come to our ED. So for our patients who are less than 20 kilograms, who are moderate to severe, they're getting those 2.5 milligram treatments 3 times. So for a total of 7.5 milligrams over that first hour. And then our patients that are 20 kilograms or more are getting those 3 5 milligram treatments back to back, so a total of 15 milligrams. We found that children tolerate albuterol really, really well. So most of them tend to have tachycardia. Some of them will have a little bit of jitteriness, particularly if they've been doing very low dose albuterol at home. They'll kind of complain of feeling different. And we do see some nausea associated with it. But again, overall, kids tend to tolerate this very well. And our hope is that this aggressive early treatment is helping to prevent a more protracted course in these children. Okay, so moving on to our second hour, we're repeating our pediatric asthma score, so we're assessing them again. And in patients who are mild now, we are holding off on albuterol. If they've been mild the whole time, then often this is a time where we can think about discharge. So patients who are tolerating PO intake and saturating normally on room air, we can ensure they have follow-up and get them going home. For kids who are moderate or severe, if they're mild at this point, then we'll usually observe them to make sure that their wheezing and their respiratory symptoms aren't recurring before we send them home. So that's what will happen in this second hour. Whereas our kids who are moderate or severe in this second hour, we're typically continuing them on more albuterol. So at this point, we're transitioning them from the back-to-back treatments to continuous nebulized therapy, which we usually give at a dose of 20 milligrams per hour. In our more severe children, we're also considering some adjuncts, and I'm going to talk about those again in just a couple of minutes. And then it's sort of more of the same for our third hour. Hopefully, some of those children who have been and staying mild are being moved towards discharge at this point. For our kids who are moderate and have not worsened after their hour of continuous, then we're going to try to hold off on their albuterol for a little while and observe them. I want to see if they're able to sort of maintain moderate, and the thought is that they will be admitted at that point because we haven't resolved them, but they don't seem to be worsening. And then in children who are staying severe, who have started off moderate and have become severe, then we are continuing the nebulized continuous albuterol. And if we haven't given adjuncts before this point, we'll be doing that here. And at this point, children who are severe, despite that first continuous hour of albuterol, we'll be talking about admission to the PICU typically. So just a few minutes for each of the adjuncts that we were talking about. So ipratropium is the first one. So I was talking about those 3 back-to-back treatments, which we often give with duo-neb, so albuterol plus ipratropium or Atrovent. And we do that because there are some studies that have shown that there's decreased rate of hospital admission in kids who use who were given ipratropium in their as part of their ED stay compared to kids who didn't. And so it's not the strongest evidence I've seen, but it is relatively consistent. And so we have opted to use that for our first 3 treatments. There have not been studies showing any inpatient benefit. So studies that have looked at length of stay overall or at the need for ICU admission with ongoing ipratropium therapy has not been shown effective. And so for that reason, we typically stop the ipratropium after those first 3 treatments. If for some reason they sort of come in the middle of a pathway, particularly patients who are transferred in, if they haven't gotten ipratropium in the ED, we'll give it sort of before they leave the ED. But again, then it typically stops after that.
Yeah, and I would add for that, usually the only population that we typically would use it in the inpatient setting would be more of our child who might have like chronic lung disease or some other underlying problem. But for our asthmatic, our clinical practice is consistent with not utilizing it in the inpatient setting.
One of the other adjuncts that we tend to use in our patients with moderate to severe asthma is IV magnesium sulfate. And this is another one where the evidence is a little bit sparse. There are studies, but they have small numbers. They have some different methods from each other, and they have some different outcomes. So it's been difficult to sort of pool the results and feel very confident about them. But they're definitely suggestive of a decreased admission rate in patients with moderate to severe asthma who are treated with IV magnesium compared to patients who aren't. Fortunately, we have a colleague in the Pediatric Emergency Care Applied Research Network who's actively studying IV magnesium in our patients with moderate to severe asthma to see if it affects the risk of hospitalization. And so I'm hoping that over the next couple of years, we'll get some information on both the optimal timing of when to give the magnesium, because there's debate about that, as well as optimal dosing for the magnesium. This same colleague, as well as some of these other studies that I've talked about, have looked at adverse events in patients who receive IV magnesium. There's concern for hypotension in these patients because of the smooth muscle relaxation that can go with magnesium. But overall, those rates of adverse effects are relatively uncommon, and very few of them have clinical significance. So we feel like it's a safe medication to use, even though the evidence is a little bit sparse. The dosing range in the studies is anywhere between 25 and 100 milligrams per kilogram, but typically maximum doses are about 2.5 grams. So our practice at UC Davis in general is that if patients are still symptomatic after that third neb, so you can picture they're finishing their first hour, we're reassessing them and they're still in that moderate to severe, then those are patients where we will place an IV and give magnesium. If they have an IV in place and we assess them as moderate to severe, some of us will do magnesium earlier in the course as well. And then patients who present severely will often get their IV placed right when they come into the ED, and we'll get the dose then. We dose it at 50 milligrams per kilogram with a maximum of 2 grams. And many of us also give 20 ml per kilogram isotonic fluid bolus when we give the magnesium. I sort of anecdotally, I haven't seen a lot of hypotension associated with magnesium, maybe because I am always bolusing my patients at the same time. My thought is that it doesn't hurt to give the fluids anyway, because many of these patients, I think, have decreased PO intake associated with their exacerbation, as well as some increased insensible losses from their increased respiratory rate or from concurrent fever associated with an infectious trigger. So they tend to do well with the fluids that we give with them. And then what about a role for parenteral beta agonists in these patients? We tend to use them in our more severe subset of even the severe patients. So patients who are presenting in extremis. So patients who I'm worried, are we even going to have time to get an IV in and get a mask on this patient and get steroids in? Is a patient that I'll consider giving intramuscular epinephrine to. So we dose it at the same dose that we do for anaphylaxis. And because of that, we have it readily available, in the emergency department on the code cart so we can administer it quickly. And the sort of general thinking on that is that by giving it parenterally, we're sort of bypassing those severely obstructed airways to allow administration of the beta agonist, even if it can't pass through the airways because of obstruction.
And if you had an IV, do you guys still give it IM? Or what do you do in those cases?
I typically do. I feel like more of these patients come in without IVs, but I think just because of the ease of dosing and the familiarity with giving it IM, I think that we can get it in faster and safer if we give it intramuscularly. So even though that's not my usual practice with kids in the ED, I try to avoid extra injections. This is a case where I think I would give it that way just because I feel like again, sort of the safety and the ease of getting it quickly is faster.
Yeah, and I think for some of us too, having a consistent practice is helpful in terms of not having people, in terms of a safety perspective, get mixed up between the different concentrations of epinephrine and how to administer those. And so when we've utilized something like that too, we've tried to be really consistent in terms of the route and the concentration and dosing.
Agreed. And then for our patients who are sort of farther along in their course but don't seem to be responding, so we're sort of giving them sort of all of the adjuncts that we've talked about, and we haven't had improvement yet, and they're still having severe PAS scores, we will consider terbutaline in that population. So terbutaline is one that you can give intramuscularly, but sort of as you were just saying, Heather, I think that for consistency, this is one that we tend to give via IV mainly. And we'll give it with an IV bolus. So we'll dose 10 micrograms per kilogram over 10 minutes. And then we do a lower dose infusion that we will do continuously. And these kids, because of the risk of tachycardia, because they're often getting other beta agonists, most often albuterol, we can see pretty significant tachycardia, and we will put them on continuous cardiac monitoring so we can monitor for any dysrhythmias as well. And then moving a little bit away from our therapeutics into diagnostics, there's one diagnostic modality that is sort of intentionally left off, the mild to moderate portions of our pathway, and that's chest X-ray. And that's because there's some good, solid data out there that chest X-ray is not particularly helpful routinely in these patients. It was actually part of the Choosing Wisely campaign for the Society for Hospital Medicine that we not order chest radiographs in children with uncomplicated bronchiolitis or asthma. So again, in sort of those routine presentations, particularly in those mild to moderate categories, I think we don't need it in most of those kids. There definitely are cases where we consider it and where we still find utility in it. And I think that most of those are kids who have high fever, kids who have focal lung findings, and especially focal lung findings that persist despite albuterol. I feel like we can see some sort of patchy atelectasis or hear some patchy atelectasis with a little bit of asymmetric wheezing, but it tends to sort of normalize and become more symmetric as we treat them. And if it doesn't, then that's a case where chest X-ray could be considered. In patients who present with severe presentation, particularly because of the risk of pneumothorax, we will consider it. And then in kids who have persistent tachypnea, persistent hypoxemia, or significant chest pain, despite our pharmacologic therapies, we will consider chest X-ray in those because that's a case where we might be missing a pneumonia. And then we sort of touched on this as we were talking about the hour 2 to 3 of our ED pathway, but just to sort of summarize our admission considerations for patients with asthma, most often patients who are still having symptoms, so meaning respiratory distress or wheezing after they've gotten that initial round of 3 nebulized back-to-back treatment and steroids, or if their symptoms resolve but then recur within the 2 hours after that period, then we will admit them thinking that that is probably more frequent albuterol than families can safely be giving at home without more observation. And then for patients who need continuous albuterol for more than an hour, again, the thought is that weaning that albuterol is going to be a more protracted process than what we would do in the emergency department, and they're not going to be ready for home particularly soon, so admission is an option for them as well. And then our ICU admission is typically for patients who are still having severe respiratory distress, so patients with that severe pediatric asthma score after their initial treatment, and then again, usually after adjuncts, including IV magnesium. And then we typically try at least an hour of continuous albuterol to see if we'll sort of get them to the point where um, their systemic corticosteroids are starting to work and maybe we're starting to open them up a little bit. But if not, and they're still severe at that point, then that's often when we will be talking to the ICU.
Yeah, and I would add, one of the key components I think of taking care of these patients is having respiratory therapists involved who can help us monitor the patients and move their care forward. And so part of one of the goals of this pathway more long term is to move towards having some of these patients who require continuous albuterol but are stable and or improving to be able to transition to care on the floor. And so kind of separating out the patient who, again, is improving or moving in the right direction versus the child who's more concerning and still staying in severe respiratory distress. And so that's one of our more long-term goals that we'll be working towards in terms of people thinking about transferring patients and level of care in time. One of the interesting things as we were looking at our practices as an institution was also evaluating, looking at the outcomes for our patients who were admitted to the ICU, who were started on continuous albuterol. And it's actually, for us institutionally, pretty rare that those patients end up, once they've been weaned off of continuous, for them to go back on continuous, and also quite rare for patients who are transferred out of the ICU to end up needing to require ICU care again later in their stay. And so for most of these kids, once they kind of hit a trajectory and those steroids kick in and they start to improve, we see that that continues even if they're requiring more intensive treatment that can be done at home. So thinking about admission, our first step is our asthma H&P. And so there's specific components that we think about in these patients in terms of what we want to get in the history. And so we want to assess the frequency of symptoms for that patient. How often are they wheezing in a week? Are they having a lot of cough? Are they getting short of breaths when they're exercising? Sometimes families haven't always, especially early in a patient's diagnosis of asthma, made the connections that some of those symptoms may be related to asthma. And then I think also for our younger patients, it can be sometimes confusing because they have so many viral respiratory illnesses. So trying to tease out kind of what may be from asthma and what's going on beyond kind of what we would typically expect for a viral illness versus the kid who kind of can't kick things. Another significant red flag would be if they're having nighttime symptoms or if they have any activity related symptoms. So the kid who goes to PE and has to stop and catch their breath or is coughing a whole bunch. We also want to assess the patients, in particular, their atopic symptoms. So I always ask families if the patient's ever had eczema, and then also talk about seasonal allergies or other allergic or environmental symptoms. In terms of their past medical history, we want to assess whether they've ever been to the ER or been in the hospital for any respiratory illness, I ask. And then I typically will ask also if they've ever received albuterol in the past. And then if they have, try to find out a little bit more about what that looked like. Was it a patient who just showed up in the ER and got a single dose, or was it a child who was admitted and got persistent dosing and was sent home with albuterol? And then finally, in terms of thinking about risk factors, also wanting to know if the patient has ever been intubated. For their family history, we know atopic disease is there's a genetic component to that. And so we always want to talk through and see if they have any first degree relatives who might have asthma or other allergy type symptoms. And the vast majority of the patients that we ultimately diagnose with asthma do have some kind of family history, at least atopic, but often a sibling or a parent who has asthma. We also want to think about tobacco smoke exposure. So does anybody in the family smoke, and what does that look like? Are you smoking inside the home, outside the home? And then for our adolescent population, also thinking about them, are they vaping? Are they having any tobacco use? For that population, also considering doing it in a HEDS assessment and doing it separate from the parents to try to elucidate whether that may be one of the components of their disease. And then finally, thinking about medications. So, I think it can be really confusing for families to understand the difference in the medications because we have one medication, typically albuterol, that we're giving and we're asking them to use as needed. We oftentimes will give them inhaled corticosteroids, which they're supposed to use every day, even if they don't have symptoms, and often twice a day. And it can get confusing which is the which and why you're taking one and when you're supposed to take it. And then we'll kind of talk a little bit later in the presentation about how some other changes in how we're managing asthma. But I usually try to use that as an opportunity to really kind of figure out what the medicines are, but also what the family's understanding of the medications are and how they're utilizing them.
I feel like a lot of my medication history in patients with asthma has to do with the color of the inhaler, which I used to sort of roll my eyes at. But then I realized that, when you put it in the canister in the case, you actually can't read any of the words on it. And so you can just sort of see that little bit of color at the top. And so I think, a lot of families are identifying it as I use the red one as my rescue and the blue one is, his everyday preventive medicine. And so at least I feel like that's not consistent. There's not a consistent color scheme with it. So I do a lot of, looking at the inhalers myself to figure out which one and make sure that they're using them correctly.
So I wanted to give people just an overview of our pathway just to kind of visually orient you. So you can see on the left-hand side, this is our complete inpatient pathway. The kind of darker blue boxes on the left-hand side start with continuous albuterol, and we'll go through this in more detail. And then at the very end of that algorithm, we end with albuterol 6 puffs every 4 hours. And that's when a patient is able to consistently tolerate that, that's when we are moving towards discharge criteria. You can see for these patients on the right-hand side, we have our pediatric asthma score that we're using to evaluate the patients. And then we'll go through some more details in terms of when we involve our pulmonologist as well as our discharge criteria. So this is that first half of our pediatric asthma pathway in terms of how we're going to manage them with albuterol. You can see on the left-hand side, we have phase 1. So for patients who are getting admitted and have a PAS score of 12 to 15 on admission, we'll start continuous albuterol. Our dosing continues to be the 20 milligrams per hour. And then as we were doing in the ER, we continue to do an hourly assessment and reevaluate their PAS score. For patients who have a PAS score um, that continues to be 12, we will continue the continuous albuterol. But for patients who begin to show improvement and have a score of less than 12, we'll go ahead, similar to the same kind of framework that we use in the ER, and stop the albuterol and then assess in an hour and make sure that that patient can maintain either staying stable or ideally improving. And as we've mentioned, at that point, we're either the ER has already put the patient on steroids or often our community hospitals. And so it's also in that window where the patient has had some time for those to start to kick in. As we progress down the pathway, our first step, if the patient continues to do well and has a score of less than 12, to an intermittent albuterol is going to 12 puffs every 2 hours. And then we continue to score, despite the fact that they're only getting the treatment every 2 hours, we still score them hourly because they're early in their illness and also higher risk in terms of the intensity of the treatment that they're requiring. You'll see on the left-hand side, there's that little box that says PAS of 8 to 11 on admission. And so many of our patients get admitted to the floor and do start initially on intermittent albuterol. And that's some patients who just got the 3 back-to-back nubs in the ER. It's also some patients who successfully transition from continuous albuterol to intermittent in the ER as well. We do, in terms of rescue in the inpatient setting, have in that orange box on the left-hand side for patients if they either get worse or aren't improving, as part of our pathway, have it where the respiratory therapist can give an albuterol nub, and then we'll reevaluate the patient and see if there's anything else we need to consider in terms of treatment. On the right-hand side, we have notes about steroids, and I'll talk in a little bit more detail. But our typical dosing for prednisone, prednisolone, or methylpred is 2 mg per kg per day. It's pretty rare on the floor that we end up using methylpred. Some of these patients don't even have an IV, and then for the vast majority of them, they're able to tolerate the oral medications. And so our most common is the prednisolone, so that we have a liquid formulation for our younger kids. And then most often we'll do the 2 mg per kg per day, but we'll typically divide that BID. So it ends up being 1 milligram per kilogram per dose BID. Alternatively, we do sometimes use dexamethasone. I think at UC Davis, our general kind of culture is that most of us have continued to give prednisolone. Some children's hospitals have actually, though, transitioned to primarily giving dexamethasone. And if we do dexamethasone, we do typically 0.6 mg per kg per dose, and we'll typically do a total of 2 to 3 days. So I wanted to highlight a few other things about this. In terms of dexamethasone, although the practice is sometimes variable, we do often now have the support to say that there's evidence that the dexamethasone is equally effective. And that comes from the multiple retrospective studies from the Pediatric Health Information System database. And then in addition, one of the other things that I wanted to say, in the inpatient setting, as I mentioned, we often do 1 mg per kg per dose BID. But then we also end up, as those patients are going out the door, for the more mild patients, I'll often switch them to 1 mg per kg per day for the kids who resolve really quickly. For the kids who take a little bit more time to resolve or were more severe, I'll continue them on that 1 mg per kg per day BID. The next thing that I wanted to mention is kind of going from our pathway. We had left off doing albuterol 12 puffs every 2 hours. Our next step typically is going to every 3 hours. But you can see there's a green box on the right-hand side. And what that summarizes is that if our patients are really progressing and improving significantly, then we can skip that every 3 hour step and go over to every 4 hours. And so we use kind of clinical evaluation to make that determination. And then once we're in that phase 4, doing the 12 puffs every 4 hours, our final step is the 6 puffs every 4 hours. And so for our patients, we will typically want them to go through 1 round of 6 puffs every 4 hours, meaning they get that dose and then we wait 4 hours and give us another dose and make sure that they can continue to stay stable with the intermittent every 4 hour dosing. Other things that I wanted to highlight in terms of when we think of involving our pulmonologists, we do that if the patient requires ICU level of care. If they're already followed in their clinic, we'll often involve them. And or if we are kind of assessing the patient's symptoms at baseline and noticing that it sounds like the patient may need a step up in their asthma control. Other things that we use in terms of like discharge criteria, I've mentioned what we are looking for in terms of their albuterol. We want to make sure that they're stable, greater than 90% or greater on room air, off of oxygen, that they're taking good PO, and then also do asthma education. And we tend to spend a lot of time talking through things with the family, like we've kind of mentioned, in terms of clarifying what medications for what, having them reiterate that back to us to make sure that they understand what's happening as best as we can communicate that with them. We make sure that all of our patients leave with a spacer, so we know that without a spacer, albuterol administration by an inhaler is ineffective. We do sometimes use nebulizers in our inpatient setting, but we typically do actually try to use inhalers for kids other than if it's like a one-time trial. But for kids we really think are asthmatic and are going to continue to require intermittent albuterol, as Dr. Tzimenatos had mentioned, we try to actually have them use the spacer so that they can use that as an opportunity to develop good technique and to understand how to use it at home. In addition to that, we'll review and make sure they have prescriptions if they require a controller medication. We'll make sure they have a steroid burst, and so they'll finish out their systemic steroids. We'll have them leave with an asthma action plan, so information about when they need to call the doctor or how to use their albuterol and step it up and when to return to care. And then we'll typically have them try to follow up their primary in 1 to 2 days.
And we definitely hope that all of our patients just sort of progress very neatly down the asthma pathway. And I would say the vast majority of them do, but we definitely have patients that have to sort of come off the pathway because they are not responding as we would think, or who sort of don't make it onto it initially because of their degree of severe respiratory distress. And that's a group that we think about doing additional positive pressure ventilatory support for. So it's interesting. I feel like with with the widespread use and good evidence of high-flow nasal cannula in pediatric bronchiolitis, there's been sort of an urge to use it for patients with asthma as well. But there's really limited data in asthma, and there's not been great success in using it as a mode of respiratory support in these patients. And then combined with that, there's some concern that if you try to give albuterol in line through a high-flow nasal cannula circuit, that we're actually not getting effective albuterol delivery. It has to do with the particle size and the flow rates not getting the medication delivered to the size airways that need it. So typically we avoid high-flow nasal cannula in our patients with asthma, and if they are needing additional non-invasive support, we will go to CPAP and tend to use that instead. And so for those patients, because if we're administering albuterol, we typically want to use a full face mask. We do want to make sure that they're alert, that they're tolerating their secretions, and protecting their airway well. In some of our youngest patients, they can get anxious when we try to put that full face mask on them, especially if they aren't used to wearing a nebulizer mask. And so we sort of are trying to thread that needle of balancing the anxiety of the patient with not wanting to give them medications that are going to decrease their respiratory drive. So sort of doing some minimal medications for anxiolysis, either some low dose IV midazolam, or for patients that are needing it longer term, thinking about IV dexmedetomidine or IV ketamine as low-dose infusions as well. And then we'll typically start at CPAP with pressures of 5 and then sort of titrate them up either just up on their CPAP or transition them to BiPAP if it seems like they're needing additional support. But in doing this, we're able to administer their albuterol as well as provide some respiratory support. And our whole goal with this is to avoid intubation if at all possible. The indications for admission in, indications for intubation in these patients is really just patients who are progressing to respiratory failure despite our maximal pharmacotherapy, as well as our trial of non-invasive positive pressure ventilation. So these are patients where we sort of already tried all of these things and they're still worsening. It can be difficult to assess worsening in these patients, partly because we don't want to use isolated blood gases to determine how the patient is doing. Just a single isolated hypercarbia, so elevated PCO2 on their blood gas, can be very concerning when you see it, but in a patient who's just starting therapy, it could be that that's going to improve relatively quickly. Likewise, patients who are very sleepy as they're going through therapy can be difficult to assess if they are becoming more somnolent because they're worsening, because they're retaining CO2, or because they've actually finally managed to get comfortable from a respiratory standpoint. So I would say that we use blood gases in a serial manner to see if we're seeing trends of worsening combined with their mental status of either agitation if we're sensing air hunger, or somnolence if we think that they're sort of moving towards that. And we'll use those as indications for intubation. If we do need to intubate, ketamine is our usual medication that we use for induction because of its bronchodilatory as well as its sedative effects. And we know that mechanical ventilation for kids with asthma is particularly challenging due to the degree of airway obstruction and because it's so difficult for those children to exhale appropriately during ventilation. So because of that, there's risk of air stacking and risk of barotrauma. So the real risk in these patients doesn't necessarily happen right with the intubation, but it's with the ventilation attempts afterwards. There has been significant looking at which specific mode of ventilation is most beneficial in these patients, and it seems like there's quite a bit of controversy in the critical care literature about it, but really nothing has come out on top. Really consistently what we know is that these children do well with or do better with a respiratory rate that's lower than what you would expect for physiologic age. The idea being that we want to use a short inspiratory time and really allow a prolonged expiratory phase in these patients, again, to prevent that air stacking and decrease the risk of barotrauma. We also tend to allow these patients to be more hypercarbic, so we're not aiming for perfect blood gases. And blood gases on these patients tend to look worse than patients who are intubated for other reasons. But again, sort of like albuterol, this is something that our patients, pediatric patients particularly, tend to tolerate well, especially patients who without complex medical history and without congenital heart disease. We can let their CO2 creep up a little bit while we, again, try to limit that barotrauma. And then in our very most severe patients, neuromuscular blockade for muscle relaxation, along with really strong deep sedation medication can help the patient have asynchronous breathing with the vent, which can make it more difficult to ventilate them and add to the risk of barotrauma.
The next thing I wanted to highlight is one of the important ways that we need to start thinking about these patients who do indeed have asthma is classifying what their disease is. And so you can see that this figure, this is from the 2007 clinical practice guidelines. Our classification hasn't really changed significantly. And there's different charts, but this one in particular is for our kids who are 0 to 4 years of age. You can see across the top that we're going to stratify the patients of whether they have intermittent versus persistent symptoms. And so going through kind of that intermittent category for those patients, they have symptoms less than or equal to 2 days per week. They don't have nighttime awakenings with asthma symptoms. They're not having to use their albuterol more than 2 days per week. They are having normal activity, so not having any limitations when you're talking to them about running around or sports or being at the playground. And then in terms of kind of thinking also about their risk, for kids who have had 0 to 1 exacerbations in the last year, we would think of them as lower risk versus kids who have had more exacerbations being higher risk and potentially considering that they have more severe disease. I wanted to go also through kind of thinking about our kids on the other end of the spectrum. So kids with severe persistent asthma. So those are kids who have symptoms throughout the day. They may have nighttime awakenings greater than 1 time per week. They have to use their albuterol several times per day, and it does interfere with their normal typical activities. And so a lot of times, again, this is really teasing things out with the family. Sometimes patients themselves aren't recognizing that it's the asthma that's affecting them because they just kind of for kids who maybe are undertreated and have gotten a little bit older and haven't been treated, they've kind of just gotten to the place where they've accepted that that's their norm instead of recognizing that maybe those are asthma symptoms and something that we can intervene and improve their quality of life. So when we're thinking about discharging patients, we go over an asthma action plan so that they have a clear idea of what to do if the patient has symptoms at home. We prescribe and review their controller medications if those are indicated. And then we review tobacco smoke exposure because that's one of the biggest risk factors for these patients. I included in this the 1-800-NO-BUTS line. So resources for caregivers and family members who may be interested in smoking cessation or want to have that discussion. They have not only the phone line, but lots of other modalities now with text and the app and different things, as well as some nicotine replacement products for family or caregivers that are interested in. So the next step, and I just wanted to highlight a few of the steps on here, things that are kind of updated and that have changed in our practice. So this is for asthma treatment, again, for our population that's 0 to 4 years of age. And I starred one of the things that I wanted to highlight. So you can see it on the table, but then on the right-hand side, I summarized it, that for our kids who have intermittent asthma, step 1 is considered a short course of inhaled corticosteroids at the start of a respiratory tract illness. And so in the past, typically for kids who are on inhaled corticosteroids, again, it was like an everyday thing. And for a lot of our more severe patients, that's still the case. But for this younger group who may just be having, every time they get a viral illness, they're having wheezing, they're having coughing, they're taking longer to get better than their siblings, that we would start this at the beginning of their illness to try to decrease their symptoms of asthma during that illness. I would say we have a pretty low threshold for kids who have recurrent wheezing to go ahead and start this modality. I think in terms of like risk, it's pretty low risk. And then oftentimes, ultimately, these kids are going to declare themselves and either show that they do indeed benefit from it or show that they have more persistent asthma and may need more consistent intervention. The other thing that I wanted to highlight is in the age group that's 5 to 11 years of age and looking at step 3. So these are kids who have persistent asthma and have not shown that they're stable just with low dose inhaled corticosteroids and a short acting beta agonist. So what we're recommending now, you can see on the right hand side, I've highlighted is daily and as needed combination inhaled corticosteroid and formoterol. So a long-acting beta agonist. And so again, a change in our practice for these types of patients. The reason they specify formoterol is that that's the long-acting beta agonist that was used in the study, but we do at times use a different combo depending on what insurance covers or what the patient will tolerate. but these patients will actually use this medication. They can use it 1 to 2 puffs as needed, up to 8 puffs maximum per day. And for our older population, so for patients who are 12 up to adults, they can do the 1 to 2 puffs as needed, up to 12 puffs max per day. And so for me, I think those are some of the biggest recent transitions in terms of how we're treating our asthmatic patients and kind of optimizing them in terms of the standard of care. So in summary, we've talked through how to utilize our pediatric asthma score to assess severity. We've walked through pathways that can standardize ER and inpatient treatment based on severity and response to therapy. And then we've talked about some of the recent updates to recommendations for preventative measures upon discharge.